Hi everyone, this is Nicola Petrosillo, infectious disease specialist in Rome, Italy. This important session on COVID-19 in low and middle income countries is endorsed also by International Affairs Subcommittee of ESCMID, of which I'm chair. Please, Anya, my co-chair.
Thank you, Nicola. My name is Anja Štrbinc, and I come from the Institute of Microbiology and Immunology, Slovenia. It is a great pleasure to introduce our first speaker, Professor Maria Virginia Villegas from University El Bosque, Colombia. She works as an advisor for various hospitals regarding antimicrobial resistance and infection control. And today she will give us a short briefing on how South America became the new center of pandemic. Professor Villegas, the online stage is yours.
Thank you, Nicola and Anja and all the co-speakers. I think this is a very interesting topic. Thank you for the invitation. This is no disclosures for this talk, and I'm going to try to cover a little bit of social and economic impact, which I think is important, comorbidities and co-infection and antimicrobial resistance. So why did we become the world's new COVID-19 ladies hotspot? I'm going to try to explain that to try to move you to what are going to come next. So we have the number of cases in the region is growing because of limited resources of the health systems. The country's number of suspected cases exceeds the testing capacity, limitation in accessing health services, high prevalence of other pre-existing conditions that I'm going to show you, delayed response by some populist governments to establish the right thing to do. And of course, we have a widespread poverty and inequality that have fueled the pandemic and are likely to worsen it. So for example, Colombia, Bolivia, Paraguay, and Argentina, we started very well. We just did the confinement, the lockdown. But however, despite these measures, the number of confirmed cases are on the rise for all countries. Remember that in Latin America, there are many workers with informal jobs, around 40 to 70%, depending on the country. So they sell things on the streets. So it's very difficult for them when you lock down. Government did not enforce the measures in all countries, and that happened especially in Peru and happened in Chile, and they got a huge rise of it. And Mexico, interventions such as contract tracing to contain the positive cases were not possible due to the limited tests and resources. And today, all countries are partially in Latin America totally open, except for some international flights that they are opening now, bars, schools, and large social gatherings. And despite that the number of deaths have decreased in many countries, I do believe that we're expecting a really important rise. So the regional unemployment rate implies a historical record of 41 million unemployed, which will have an impact on the economic and social stability of other countries. And you will see that that will bring more comorbidities, of course. The most recent World Bank forecast estimates a drop in the economic growth of minus around 8, which will take the unemployment rate up to 12.3%. In absolute numbers, it means that it will rise from 26 million before the pandemic to 41 million in 2020. The poverty projection is that the rate will increase the year to 37%, bringing the number of poor people from 185 million to 230 million this year. So you can see it in this graph, which is to the left is poverty and to the right extreme poverty. And you see that in 2020, all the countries will have a huge impact. Some countries have more, depending where they started, but overall, we're going to expect that for the next year. So this is why we became actually the 7 countries out of 13 in the first places is Peru. If you count by deaths of million, this was in September 16 in Statista. Bolivia after, Chile had an impressive rise, Ecuador, Brazil, Mexico, and Panama. So you see that all the Latin American countries are in the top 13. Then it comes Colombia, Dominican Republic, and Argentina is still doing better than all of us. So how is Latin America regarding comorbidities? How would that impact? So if you see this data from 2016, where lower respiratory infections were the number 1, diarrhea, ischemic heart disease, HIV, stroke, malaria, tuberculosis, and then neonatal trauma and road injury. One of the American Marketed Intelligence believes that the top 5 health conditions right now are heart disease and stroke, diabetes, high cholesterol, high blood pressure, and injuries, but of course they are not taking into account the previous diseases that were endemic in the country. One of the most important things that I saw in the research is obesity. which has risen a lot, but this means that probably they're not going to get thinner. They're going more obese despite the economic problem, because people will start eating a lot of carbohydrates, which are cheaper, a lot of junk food. So that's really, it's going to be a big problem. So Mexico is on top, and United States, Venezuela, which you can understand why, but of course is the type of food they eat, and then they come under China and the other ones. So what can we expect with the arrival of the pandemic? Many patients are avoiding hospitals and consults. We should be prepared, as we are seeing now, for patients arriving to the ER with deterioration of the diabetes, hypertension, and even myocardial infarction. They are coming very late, even abdominal infections. The fact that all economic resources have been shifted to the acute crisis, we should expect less resources invested to prevent these diseases. Healthy activities will drop, and cheap food will be consumed, as I said, due to decreased family income. And now the next question is, what can we expect with COVID-19 infections regarding impact on pre-existing diseases? So Latin America is a region of 642 million people living in 20 countries, but you have to remember that we have chikungunya and Zika, which was rising. Additionally, we have migration from Venezuela, who many people and kids are not vaccinated. So we have seen an increase in measles and diphtheria, and from other vector-borne and zoonotic diseases such as malaria. Another scenario that you have to take into account is the Amazon jungle, where we used to have, and we still have, Chaga diseases, viral hemorrhagic fevers, such as yellow fevers, and that's going to be a huge burden impact. So surveillance for all these diseases has dropped, as all government resources have been invested in the COVID-19 pandemic. There's no money for nothing else. We should expect a huge rise in vector-borne diseases. Now, what about antimicrobial resistance? There are a lot of publications out there saying that probably people are going to become infected mainly by pneumonia due to nosocomial bacteria and aspergillus. And of course, microbiology and antimicrobial resistant patterns are likely to reflect institutional ecology. Broad-spectrum antimicrobial use is likely to be widespread among hospitalized patients, both as direct and empiric therapy, and stewardship will have a huge impact. But the problem is that many resources in the hospitals have stopped the antimicrobial stewardship programs. So I would say that in favor of bacterial resistance decrease, this is my personal view, we have better contact and droplet precautions. That's true. In the hospitals, they have increased sharply. Increased adherence to hand hygiene because people are very worried of the COVID transmission. Increased disinfection and cleanliness of the hospital. Decreased mobility of people. There's no much travel and lockdown. But on the other hand, I do believe that we have an increase in bacterial resistance due to the ICU hospitalization. These patients stay very long time in the ICU. They use steroids, immunosuppressive drugs, empirical use of broad spectrum that nobody wants to stop, prolonged periods of antibiotics associated with selection of bacterial resistance, and there actually is no treatment for COVID-19, so people don't stop the other things. What are the expected gram-negative infections in Latin America? I'm going to show you quickly. These are the prevalence of ESBLs in Latin America. All the countries, Mexico, Guatemala, Panama, have a big number of ESBLs in prevalence, especially in Klebsiella, except Mexico, which is huge in E. coli, patients coming from the community. We see Colombia. Also, Klebsiella is the #1. Ecuador is more E. coli. But we see Peru, Chile, Argentina, Brazil. We have a huge number of percentage of ESBLs in the hospital. What about the prevalence of carbapenem-resistant Enterobacteriaceae? In Mexico, it fluctuates from 5 to 13%. Maybe there's more, maybe there's under registration of it. Guatemala is getting up. They have mainly NDMs, and Panama is right there. Colombia, we have a lot of KPCs, especially we have NDMs, we have a little bit of oxas. Ecuador has mainly KPCs. Peru also have a lot of KPCs and NDM rising. Chile is more carbapenem-resistant Enterobacteriaceae due to the foreign mutations and ESBLs, but they do have also KPCs. And Argentina is the same as Colombia, a lot of KPCs, and Brazil, of course, is an endemic country, mainly in KPCs and their own infections. So in summary, the arrival of COVID-19 in a continent with social, economic, and endemic diseases has created a perfect storm. The impact of COVID-19 on bacterial or fungal co-infections is not yet known. We have not publications yet. The limitations of rapid diagnostic tests for identifying bacteria, fungus, and viral infections as well as the lack of an effective treatment for COVID-19 is leading to a rise of antimicrobial use. So a dramatic bacterial resistance increase should be expected, more because most of the hospitals don't have rapid tests in Latin America, only the very sophisticated ones. So we really don't know what's going on there. There is a bacterial co-infection. Knowing the local epidemiology is key for the appropriate use of antibiotics, because mainly they will get infection when they are in the ICU with the prevalent bacteria that they have. ESBLs and carbapenemases will play an important role in Latin America, of course, with indiscriminate use of antibiotics. And for all of the above, it's urgent to activate the antimicrobial programs. Thank you very much.
Thank you for this great talk. I have a question that is maybe a little bit outside of this lecture, but how did the public accept all of the governmental policies, the mitigation strategies? How did you react? Did you have any problems with implementing any of the control measures?
Not initially, I would say from Colombia, but I know from my friends in Mexico, especially Peru, that the government was not able to lock the people. So if you see the history in Colombia, we had a great stop of this COVID. Initially, we were almost at the same time, almost as Argentina, but then of course people get tired, the economy had a huge crisis and the government couldn't stop opening all the business and everything, so people are back on the streets, and now we're trying to be selective, but that's very difficult if we don't have enough tests to do that and to go after the person that is positive and try to lock it.
Thank you.
I ask Maria, are you experiencing a shortage of personal protective equipments? I think in your country or in other countries.
Initially, we were very concerned about that, but actually we got N95 from many countries, and we got some from China, and people do have, in most of the hospitals, they have the right equipment. The problem is doffing the equipment. The problem is when they get infected is because they want to put too much, and then of course taking all those things out, and especially the gathering. People, I would say there's one problem in the hospitals, is that as the COVID is mainly coming from the community, when people get into the hospitals, they feel protected. So we have to close all the places where the doctors and health personnel have lunch, because they get together without any protection and they have coffee and they have lunch and whatever. And many of our health people got infected because of that. It was not because of the patients. It's mainly because of the people coming from the community and their husbands and their kids, and they come to the hospital and they don't protect themselves.
I don't see any questions, but I think there are two questions. How are each of you addressing stewardship challenges in your hospitals? What is your policy and how far are the consultants following it?
Well, but the problem is, you can talk from the hospital that you work, and I mainly work in a hospital which is a joint commission hospital, and 7 more which are following antimicrobial stewardship, and we still have a lot of support from the administration. So stewardship is still working. Our main concern now is the antibiotics they are given as soon as the patient with probable COVID comes to the emergency room, and how to drop those antibiotics when we are sure there's no co-infection, there's no bacterial infection. That's probably the huge challenge of all. So we are creating protocols to try to figure out and tell people, listen, they are not infected. And as soon as you have a positive test, drop the antibiotics and wait for more signals.
Yeah. And we have another question. Did you further analyze what kind of infections the non-COVID patients of your study were suffering from?
At the beginning, when they're coming from with the COVID or before the COVID?
The question does not specify this, but maybe you can answer a little bit of both, if possible.
So mainly what we are seeing right now is pneumonias. I mean, that's the number one, we think. And when we have these respiratory panels, we have shown that there's some co-infection there. The other one is actually empiric. When you see the lungs and they're coming, we used to have community-acquired pneumonia as an important thing. We used to have urinary tract infection as an important thing. And probably what we're dealing right now is the fact that catheters-associated bacteremia in the hospital is very important because we prone the patients and it's very difficult to take care of those catheters. The same with Foley catheters, it's very difficult to clean them. So probably those are the number one and number two infections plus the pneumonia while they stay long in the ICU. I would say those are the three first hospital-acquired infections that we are dealing with.
Thank you for your answer. Another question came in. I think this is a little bit out of the scope, but in tropical countries, we have rickettsia and leptospira. Would you be okay with doxy or azit?
We do that, but we don't see it much actually. We see more malaria, Zika. We have a huge epidemic in dengue that is going down. I don't know how, because people probably are locked in their houses maybe. And of course, COVID now is the number one. So we don't see much, but we treat them with tetracyclines usually.
There are no new questions. I maybe just have one quick thing I would like to point out. I really like the thing that you mentioned, consuming food that it's suboptimal, especially given the fact that a lot of schools closed, so children are not exercising as they used to, or maybe this is just a problem here in Europe, but they're not exercising, they're consuming not healthy food, and I think this is something that should be addressed in other countries as well.
Totally, Anja. It's very interesting. When I saw obesity, I couldn't believe Mexico and other countries were obese. I mean, and now it's going to get worse because people are not exercising. Now they're starting, but still, when you drop your income in the family, what do you eat? Potatoes, rice, and whatever you have there, and the kids eat a lot of junk food.
Okay, thank you. I think we have time for one more quick question. In Chile, we do not trust the authorities because instead of listening to the scientists and experts, they have only thought about the economy and have hidden data.
Well, they have been two approaches. Governments that only look at the economic part and they open too quickly and they have a huge rise that would like what happened in Chile, and then they have to lock down very firmly, and that's why Chile jumped into the first places, and now they're starting to reopen in a very slow way. So it depends. So Colombia did the opposite, and probably we locked down for too long very early. We prepared the hospitals, it's true. We prepared the system. Everything went fine, but then when you start opening, people don't understand what's going on. It's very sad, and they do crazy things despite all this time that we prepared them with education, etc. Because people need to get out there, and they are desperate to be out. It's not easy to be inside a house which is this big, a tiny, with children there jumping around and don't allowing you to work. If you work.
Thank you, Professor Villegas, for this amazing talk and the answers. And I think it's time to move on to the next session, lecture.
Thank you, Anya. The next speaker will be Adrian Brink, a professor at the University of Cape Town, medical microbiology, infection control, and a friend and a legend. Okay. His point of view on the African COVID-19 pandemic. Please, Adrian.
Nicola, Anya, thank you for chairing it and also for the invitation. It's a pleasure here from Cape Town this afternoon to share the stage with Camilla and with Maria Virginia. So I'm going to review or provide you an overview of the background and epidemiological update for South Africa, for Africa, and then I will finish with some important considerations and major challenges regarding the impact of COVID on pre-existing conditions. I also upfront would like to acknowledge the multiple resources that I've used to be able to put this presentation together from South Africa and also from the African CDC, the WHO, and several other organizations. So in South Africa, the first case was reported on the 2nd of March, and we went through an extremely severe lockdown, which was enforced by the police and by the military. It was a military-style curfew and probably represents some of the strictest lockdowns that ever occurred nationally. But on the 21st of September, last Monday, we went back to level 1. So international flights will resume. The only restrictions are on some leisure and social and sport activities. All educational activities have resumed as we speak. There are two unique features of this extreme enforced lockdown levels. A banning of all tobacco products and electronic cigarette sales occurred after the first phase of the lockdown. This is because poorer people tend to roll their own cigarettes and then they share the cigarettes with their other friends. And so from a saliva point of view, to try and mitigate further extension of cases, that was introduced, and also a ban on all sale of alcohol. This was to free up any intensive care units and trauma units and casualty in case of a huge influx of patients. So after an initial peak, or our peak between the 10th and 16th of July, we currently have around 1,000 to 2,000 patients per day, new cases, without any evidence of the second wave at this stage. One of the extra measures we have is a smartphone application introduced by the government that allows for geolocation and notification of clusters in an attempt to prevent further spread. So as of yesterday, we have a total of 670,000 cases with 6,283 deaths. If you look at the daily infection increases from the first 100, you'll note that the peak was flattened by this extreme lockdown from the start that was enforced, as I said, as opposed to the many other countries that had that kind of trajectory. Once that extreme lockdown commenced, we had immediately an impact on the curve. So at the moment, this is the top 10 as of this morning. South Africa has the 10th most cases of all globally. If you look at the current positivity rate, it's the same as India. It's around just under 10%. And then the cumulative confirmed deaths are shown in this graph, which is per million people. If you look at the comparative case fertility rate as of today, South Africa and India at the bottom here compared to Mexico or Italy. The reasons for this remains unclear. So as of yesterday, we only have 4,300 patients in hospital, of which 643 are in intensive care. And of those, only 265 are currently being ventilated. The healthcare workers cumulatively represent 4% of all admissions to hospital since we started in February. The fertility rate overall, excluding hospitalized patients in and outpatients, is 2.4%, and the overall recovery rate is just under 90%. When we go to cumulative or to sentinel detailed hospital surveillance, the most common comorbid disease associated with admission to hospital is hypertension, followed by diabetes, as well as HIV and active tuberculosis. I'll revert back shortly with new data. The majority of deaths occur in the age group 60 to 69. The median age is in fact 63, and the in-hospital case fertility rate is 19%. The CFR is higher in males than females, which is significant. But when we look at the impact of comorbidities, for every 100 person in the public sector that died from COVID, we can attribute 50 to diabetes, 8 to kidney disease, 10 to concurrent HIV, 2 to current TB, but I'll give you some more detail about that shortly. This is a regional population cohort study in the Western Cape, which is my province. It is the second largest populated province in South Africa, which provided in-depth detail of, in the population cohort study of the hazardous risk ratio with TB and HIV at the bottom here, stratified diabetes pending the HB1C and all those kind of outcomes. But in adjusted analysis, HIV increased the risk of COVID mortality by an adjusted hazard ratio of 2.14, which was very similar across strata, pending the viral load, pending the CD4 counts. But current and previous TB also increased mortality by 2.7 and 1.5 respectively. So the standardized mortality ratio for COVID-19 death associated with tuberculosis with HIV was 2.39. Regarding the African continent, the first case was described in February in Egypt. The majority of the countries are experiencing widespread community transmission. Since the 1st of May, most African countries started easing the restrictions. All African countries can do testing now, with 14 of the countries performing more than 100 tests per 10,000 people. Initially, it was only South Africa and Senegal in February that could do COVID testing. The partnership to accelerate COVID testing, or so-called PACT, resulted in 12 million tests being made available and actually performed. On the 3rd of September, the director of the African CDC claimed a 14% decrease overall in the last 2 weeks in Africa. So as of yesterday, there were just under 1.5 million cases and 35,000 deaths. This is the top 10 African countries. What you would also note is that this might be, compared to the population of Nigeria and so on, also differences perhaps in the testing capacity. But although most countries in Africa and the continent are on a plateau, there are some countries like Nigeria, Libya, and so on, which have shown dramatic increases in both cases and mortality. There are also substantial testing policy differences between the different countries. In dark blue are those where you have open public testing or testing with anyone showing COVID symptoms or even asymptomatic people. But for the majority of the continent, testing only occurs in specific key groups, patients admitted to a hospital, came into contact with a known case, returned from overseas, etc. Thank you. I'd like to end this presentation with some important considerations and major challenges for the African continent. The first is the issue of the perceived lower mortality compared to, if you compare South Africa's overall recovery rate of just around 90%, with Africa around 82% versus global data. One of the reasons of this has been supposedly relates to BCG. The so-called BCG index has shown that for every 10% increase in the degree of universal BCG vaccination has led to an overall 10% reduction in COVID mortality. It's thought to occur through trained innate immunity, but unfortunately, the jury is still out, and there are several countries that are participating, like Colombia, South Africa, where BCG vaccination for healthcare workers has a 1-year outcome of acquisition and mortality. My colleagues here at the University of Cape Town have already recruited about 400 cases, but globally there are 20 trials. So I think the impact of BCG on recent BCG vaccination, we will know for a fact whether it would have had an impact on the mortality or not. And then I would like to quickly finish this presentation, Mr. Chairman, by the issues as highlighted by Maria Virginia, and that's the continuity of essential health services. This is a report from the WHO, and you'll see that antenatal care, or for example, routine immunization in the continent has dropped by 61%. And then outbreak detection and control for non-COVID related diseases by 45, or continuation of antiretroviral therapy and so on, as has malaria diagnosis and TB case detection and treatment dropped by 42 to 46%. So the impact of COVID and this issue is going to be long-lasting beyond COVID per se. In HIV, the greatest modeling impact appears from interruption of antiviral therapy. For TB, it would be reductions of diagnosis and treatment of new cases, and malaria is the interruption of net campaigns. So malaria, what is expected if the mosquito nets are not deployed, as I showed you, an additional 800,000 malaria deaths in sub-Saharan Africa is expected. And regarding TB, we know that global TB case detection has dropped by 25%. And I would like to finish this presentation by showing you in South Africa, our TB testing decreased by 50%, including confirmation with gene experts, we declined by 33%, including drop by 50% in initiation for drug-resistant TB, and as well as a 22% reduction in the mean HIV viral load testing and CD count test. So in conclusion, despite low testing capacity compared to the world, we currently have 1.5 million cases with 35,000 deaths, with a recent increase in reported daily cases and deaths in some countries. Although a second wave has not been recorded, the potential for widespread community-based transmission remains high. And if resurgence does occur, the changes in infection pattern and the impact remains to be seen. However, the biggest impact, potential impact of COVID would be in sub-Saharan Africa on HIV, TB, and malaria, as well as the potential implications on maternal, child, and neonatal health, which will remain a challenge long after the COVID pandemic. Thank you very much.
Thank you, Adrian. There are some questions. Please, Anya, could you help me in make the questions?
Yes, thank you. So the first question is, did the ban on tobacco and alcohol work as intended?
What had happened was that the ban on alcohol had a significant impact on freeing up casualty and emergency care and ICU beds, which was the aim of the lockdown. In anticipating the projected numbers, which we didn't get to, the alcohol ban was simply there to free up another 500 to 1,000 intensive care beds. I can't remember the exact date. The impact of the tobacco ban, Anya, is far more complex to estimate. You know, we have masks have been mandatory for many, many months now, as is social distancing and all the other measures. So how you determine the impact of a ban of cigarette smoking per se on its own, as a confounder with all the, or on multivariate analysis to look at the impact is going to be impossible. But that was a decision by the government to try and mitigate sharing of cigarettes amongst poor people or hand-rolled cigarettes.
Yeah, I think this was wonderfully communicated by the government, since this was would never be possible to implement in our country.
Well, it didn't mean that people did stop smoking. They went across the borders illegally. There was some illegal trade, but you couldn't buy cigarettes or alcohol for a long time.
And the second question is also related to the tobacco ban. This was explained in the lecture, but I think if you can just briefly again explain what was the idea behind the tobacco sales. The person who asked this question understands why the prohibition of alcohol sales was implemented, but why did they decide to ban tobacco?
Well, amongst the poorer communities, which is a substantial proportion of South Africa, if you have a cigarette, however you bought it, it's quite traditional to share a cigarette amongst friends. So you don't smoke the cigarette on your own, and because of the potential of saliva and spreading it in that way, even if it's not a bought cigarette, if it was a rolled cigarette, which is also common, but tobacco, they have one puff and then they give it to their friends, and 10 or 12 people in a little circle will share one cigarette. And that would mitigate, the ban theoretically would mitigate further spread via saliva.
Thank you for the explanation. Another question, did you have problems with the availability of healthcare workers since many were also infected? If so, how did you respond to it?
We didn't have a shortage of healthcare workers, and where we did have a shortage, for example, in some of the testing clinics, a lot of postgraduate medical students and those kind of paramedic or para-healthcare primary workers were called in to assist with triaging and so on, but we didn't have a shortage per se.
Thank you.
Maria wants to ask a question.
Yes. Hey, Adrian, wonderful talk, as always. Let me ask you something. At least in Colombia and many Latin American countries, the money from the consumption of alcohol and smoking goes to the government to pay education. So that was one of the huge problems when they stopped the bars, the discotheque, etc. Isn't that the same in South Africa? That in a way they are, of course, decreasing their income for social investment, etc.?
No, the tax on alcohol and wine sales and the tax on cigarette sales goes to the central government's overall income, and then from there it is spread. It's not linked to specific initiatives such as immunization or schools and so on. The projected loss of income due to the alcohol ban and due to the cigarette ban was substantial. And to make up the loss, there was a presidential fund where many corporations and companies donated billions of money to, so that could offset the loss in income or revenue from those two taxed products.
Okay. Thank you.
Okay. Due to the time constraints, we will have one more question. Are our death rates unreliable due to lapses in capturing? Many deaths have been labeled something else, like MI instead of due to COVID. Also, we do not test cases that are broad death.
Sure. So the issue about the lower case fatality rate in South Africa versus, for example, Italy, is still ongoing. And analysis of how COVID deaths are reported or COVID pneumonia deaths are reported are being performed to ensure that the data, at least from South Africa, is as accurate as it is humanly possible.
Thank you so much for the great lecture and the answers. Unfortunately, we have to move on. I would like to present the final speaker for today, Dr. Camilla Rodriguez. She is the head of Indunja Hospital from Mumbai, India, and she will give us a talk titled "In the Middle of the Storm, India and Neighboring Countries." Please, Dr. Rodriguez.
Thank you. Thank you, Anya. I'm not the head of Hinduja Hospital. I'm only the humble head of microbiology. Nevertheless, thank you, ESCMID. Thank you, ESCMID, for inviting me. And friends, as lives and livelihoods grip our world in this hopefully just once a century epidemic or pandemic. It's appropriate public health action that actually determines the outcome. And this is our world infiltrated with COVID-19 in shades of blue everywhere, all over. And I'm actually going to concentrate my talk on comorbidities as such. And it really was reported in the early days from China that patients with cardiovascular, diabetes, and chronic lung diseases did actually have 6 times more likelihood of being hospitalized and 12 times more likelihood of dying. And data from 188 nations estimated that 1.7 billion people would have an elevated risk of severe illness. And this was early data from China that actually dwelt on all what we know, hypertension, cardiovascular, and diabetes. But subsequently, if you look at this, when a patient is comorbid, almost 60% of them are affected with COVID versus the non-comorbid. And these are just done from meta-analysis. And this was a really good meta-analysis on almost 22,000 people, which showed hypertension, diabetes, and the others. One or more comorbidity was more prevalent in severe and fatal COVID. And this is data from the US, which again shows what I've been sort of stressing on in the initial introduction was 40% hospitalization and 9% with no comorbidities would get hospitalized. So why are we so fussed about these comorbidities? I think it's just meticulous management has to be emphasized for this group of people because it really does manage to control jeopardy to life. And if you look at obesity, if you look at liver disease, renal disease, every one of them seems to be a comorbidity that is directly linked to death. And what is what is so strange about these comorbidities? And it's really they all tweak on essentially one mechanism, that is upregulation of the ACE2 expression, in addition to impaired immune systems and others. And when you don't know much about a disease, you have a whole hoard of scores and risk factors and look at, I just searched the net and this is what I found. And for comorbidities, we're actually following the Charleston Comorbidity Index. And coming to my topic at hand, this is India, and this is where our world is and our neighbors live. And as you can see, Adrian showed this slide, but it's 32 million and almost 1 million deaths, 32 million affected and 1 million deaths. And this just sort of shows you, when you look at India, there has been no flattening. India has been in a pole position this month spectacularly because we've had 15 lakh new cases. That is more than 12 lakh was the US and Brazil combined. And I think, regrettably, we're on course to be the world's #1. And if you look at our neighbors, they're doing pretty well. You have Bangladesh, Nepal, Myanmar, Pakistan, Maldives, etc., barely scraping off the rock. So if you can see here, Bangladesh is here, the second most common country. And if you look at the cumulative confirmed infections till date, India soars ahead. And amongst the others the graph changes here. It's basically Myanmar and a little bit of Nepal. They're not big numbers, but they seem to be increasing. The rest of the others seem to be past their peak in daily crisis. So what happens when low and middle income countries, when their health systems are already stretched and when they're now being overwhelmed with a pathogen as COVID? There is a guard because there is a silver lining here over the Southeast Asian clouds. And just look at this. This just shows you death per million, India versus the top 10 COVID global countries. We're just 64 per million population. And believe me when I tell you, India has been extremely transparent in this. There's no fudging of data. Everything is as it is. And if you look at the WHO Southeast Asia region, these countries actually stand out really brilliantly. One is Thailand and the other is Sri Lanka. Confirmed cases in Thailand and Sri Lanka, 3,516. I can think of this in a suburb in Mumbai. And if you look at the deaths per million in India and neighboring countries, we have 64, as I told you earlier. China is also a neighbor of ours. They've come down to 59. And there we go with Thailand and Sri Lanka. No one knows what countries like Sri Lanka and Thailand are doing right against coronavirus. But whatever they're doing, so far it's working. If you look at the case fatality rate is really an imperfect measure of the risk of death, but it is really number of people who die due to COVID for every 100 who develop the disease. But it highlights in a way the shortcomings in healthcare, access, early detection, triage, critical care, etc. India is actually doing pretty good. Even if you look at Thailand, which had such a low death per million, their case fatality rate is slightly higher than ours, and Pakistan is the highest. And other countries are pretty low. And this goes to China. China is our neighbor, but if you look at the comorbidities, they actually reported initially a very low amount of hypertension being a comorbidity for COVID. This changed subsequently, and China changed, in multiple meta-analysis thereafter. The most prevalent comorbidities were hypertension, diabetes, cardiovascular disease, and respiratory illness. And this is again the same thing in again repeated slides. So if you look at the summary of comorbidities in China, today hypertension is their number one, followed by diabetes and cerebrovascular disease. What about our other neighbors, Sri Lanka, Bangladesh, and Pakistan? Strange to note that high prevalence of pre-diabetes and diabetes with hypertension, overall 1 in 2 people in these countries, this is not related to COVID, but just to give you a background on the associated hypertension and diabetes that they have in these countries. Overall, 1 in 2 hypertension were likely to have diabetes. And in Sri Lanka, it was really high, 2 out of 3. And this just sort of shows the crude prevalence. Strangely, if you could actually pick out somebody, you would look at their waist circumference. It was a better determinant of a comorbid diabetes and hypertension than the BMI. We come to India, that is in the eye of the storm. And with the initial differences in geographic distribution of COVID, we felt that, you know what, we may just escape this. We postulated it to higher atmospheric pressure, temperatures. We said we were BCG vaccinated. We had spicy food. Anyone who's come to India and had the food will not forget it. And frequent seasonal infections as influenza with possible cross immunity. In fact, SARS gave us the go-by. We really were not affected much by SARS in the early 2000s. But alas, that was not to be. The pandemic expeditiously encompassed the world's second most populous country of 1.4 billion people. And if you look at this, different times call for different measures. And there is simply no frame of reference for this pandemic. This highly infectious virus that's far more than its vanquished cousin SARS. And as per the mathematical models, 10%, if we didn't do anything, would require hospitalization, and 5% would need critical care. The lockdown gave us time to ramp up our healthcare. And believe me, India is really ramped up, at least in the state of Maharashtra, where we have the highest number. The government, the state government is really seized of the problem. And we have had lockdown after lockdown. The country had 4 initial lockdowns, and subsequently they gave it over to the states. The lockdown stopped all education, all religious places are not allowed to worship. That's a big thing in India, and no entertainment at all. Alcohol was stopped in the early phase of up to end May, but that opened up subsequently. And if you look at our comorbidities, we have the highest risk of severe death and severe illness and death, 2 or more with hypertension, kidney disease, or diabetes. And if you look at the male to female distribution across the world, it goes in sync with that. Males are more affected. And look at this. This is a nationally represented data of India. Again, not COVID, but just showing you that in India, we have a huge burden of hypertension and 70 million diabetes mellitus. So we're going to have problems. Diabetes and hypertension prevalence in the high, middle, and old age group. But strangely, we find even the younger people in the age group of about 34 to 45 seem to be getting affected. And the changing pattern of cardiovascular diseases is that 2 to 3 times increase over the last 15 years. I'm going to skip these slides, but look at this. This slide from Indian data on hospitalized young adults, young patients with low comorbidities had lower rate of complications of the disease. That essentially highlights the benign nature in the young. And look at the deaths. Unlike South Africa, which Adrian showed you, in India, we have a lot of deaths in this age group, 45 to 59. Obesity is coming up as a big problem, not only in urban India, but also in rural India. And that we need to really worry about. Of course, ILD, asthma, and cancer do play a role. Not so much. So we have a risk score that has been a COVID-19 risk score that is being tried to be implemented. I don't know how it's going on. And diabetes, look at this. Patients with severe and fatal COVID-19 are more likely to have diabetes. That's been shown. And a lot of meta-analysis from India have actually borne that out. And the death and ICU admission show a significantly higher pooled risk ratio of about 1.61 and 1.88 respectively. But then again, India is the diabetes capital of the world. Every fifth diabetic walking around in the world is an Indian. And it has been shown that there's a bidirectional relationship with diabetes mellitus, and we're seeing new onset diabetes mellitus with severe metabolic complications of the metabolic syndrome. This is a state in India where diabetes is particularly high. This is Tamil Nadu. And if you can see, just look at the last line, diabetes and hypertension really does kill. It's killing people in the blue line. These are the 60, and it seems to be really matter. Both diabetes and hypertension occurring together. These are two studies I'm quickly going to go through that are basically from India, looking at exclusive comorbidities. And if you can see, hypertension followed by diabetes, 47%, and hypertensives, and 25% diabetes mellitus in COVID patients. And actually, in another study, interestingly done in AIIMS, that is in Delhi, they found severity of respiratory illness, EMAT parameters, or lactate, rather than age or comorbidity, actually predicted death within 24 hours. And finally, friends, we have these monumental comorbidities in India. We have our share of vector-borne diseases, malaria, dengue, chikungunya, and infectious diseases like typhoid and TB. TB, let's not forget, is in everyone's backyard. And a modeling analysis to predict cumulative incidence and mortality of TB in India concluded that this lockdown would lead to almost 1.5 lakh excess TB cases. And we have these huge issues of poverty. The economic downturn of lockdown has led to increased vulnerability to TB because it's estimated that at least 100 million Indians will fall below the poverty line, in addition to whoever are there. The major cities, there's huge amount of overcrowding, there's pollution and diabetes, as we've stressed. And TB, COVID on TB does have a lot of immune mechanisms. The differences basically are between TB and COVID. TB has symptomatic, here we have asymptomatic patients. The R naught differs for both the diseases. The mortality for TB, let's not forget, if it's untreated, is 50%. And lastly, look at COVID and BCG. These were countries where low and middle income countries with universal BCG policy, and these are countries in Europe, US and Lebanon, which didn't have a BCG policy. And yes, the countries that didn't have it seem to have a higher rate, seem to have a higher rate of infection, but certainly the death rates were much, much higher. That is borne out in this really nice study that shows that in countries where BCG was part of immunization schedule, okay, it was COVID patients were getting affected. But look at the death rate. The death rate really is much lower in BCG vaccinated countries than those that didn't have it. So as Adrian said, there is trained immunity, which is basically these pro-inflammatory cytokines that may have an antiviral action. And this slide is optimistic Indian press. Masks will end up eliminating TB by 2025. I don't think they realize that the TB patients are not wearing their masks. And finally, I think we need to understand that never let a great crisis go to waste should be the strategy we should use throughout the world, because we need to a time to revisit healthcare deliveries, definitely in India, while we wait for our vaccine. We need to absolutely ramp up infection control. We need to look at hand hygiene and optimize our resources, as well as collaborate with the rest of the world, because we're all in this together. Thank you.
Thank you, Dr. Rodriguez, for this wonderful presentation. We already have 3 questions. The percentage of positives per 1,000 tests would be a better indicator than just the number of positives. Do you have any data on this?
Yes, I do have, and India has been tested. You see, the issue here is that we've been looking at symptomatic patients and contacts of proven patients. We haven't actually gone out and looked at asymptomatic patients, because unless it's a region, like, you know, if it's a containment region, it would go there. But by and large, so our testing has been slightly biased.
Okay, thank you for the answer. Moving on. A problem with comorbidities with COVID-19, since RT-PCRs persist for months, any complications related even to exacerbation of comorbidities are attributed to COVID-19. Example, liver disease patient who is RT-PCR positive, no fever, no chest infiltrates, will be still labeled as COVID-related death. Do you think that that can overestimate the effect of comorbidities?
Not really. In India, we have now had a sort of a ruling that if a patient dies, his sample is actually taken to be tested for COVID. So after death. So we're actually quite sure that these patients have died with COVID or died of COVID is different. So we're looking at death, post-death, we're actually looking even at their sampling their nose. Now, how does chronic liver disease relate to COVID? I don't know. We're really seeing the 3 top killers or associations are hypertension, diabetes, and chronic respiratory illnesses, much more than liver disease.
Thank you. I have a question from Professor Villegas. Would you like to ask the question?
Hola, Camila. Wonderful talk as always. Great panorama. I wanted to ask you, how do the government know that people are really reporting the COVID cases? How do they know they have the right numbers? And probably in India and other countries, because I'm a little bit concerned of the data from China, for example, that we were like not sure it was absolutely true.
For an initial time in India, because the government was so strict, so terribly strict, and we've had this, sort of expansion. We've had COVID containment centers, we have COVID care centers, we have hospitals which are designated. Ours is a private hospital, and we have to give certain amount of our beds, 80% of our beds, to COVID. So the government has embraced the private sector, and that has been key. But even having said that, a lot of people are scared of this because of the stigma attached. So they would rather sit at home and just wait till they're really sick. And that's what I feel, sort of burdens us in hospitals, because they come when they're, when they've been hiding themselves, and so it's a stigma. It is a stigma. There is no denying that.
Thank you.
Okay, thank you. Moving on to another question. Having a lot of cases with severe COVID, how burdened are your hospitals? Do you still have enough hospital beds also in ICU?
Strangely, yes. At least in my state, there have been a huge expansion. They've got jumbo centers. They've engaged private practitioners to help the government run hospitals. It's been a pretty sterling move, at least in Mumbai, from where I stay, which is hugely populated. So, you have mentors from the private sector helping the public sector if they're overwhelmed. It's been a lot of collaboration in these two spheres, and I don't know. And PPE, my goodness, the industry has completely. We heard of terrible stories from Italy, and we started rationing our N95 in March, and then we found we didn't have to do much because PPE is available cheap, good, and it's just being produced off the bat. So we're really not worried about shortage of PPE, and it's such a relief for that.
Thank you. I'm sorry we have to cut the session. Thank you for your collaboration, and all of you who asked questions and were unanswered, you're still invited to submit your questions. Professor Petrosillo, would you like to do the closing remarks?
So, of course, this is only a brief overview of COVID in low and middle income country, but talks were very, very comprehensive. I wish to thank all the speakers, members of the Executive Committee of International Affairs Subcommittee, and a reminder that in their country it's early morning or late evening, and so I thank you very much for your attention. I wish to thank Anya for helping me so much. I'm getting older, and all the office. Thank you very much.
Thank you.
Thank you, everyone.
Thank you. Bye-bye.
Thank you so much. Have a good
Bye.
rest of the